Breast. The breast is a modified sweat gland. Congenital anomalies of the nipple, athelia, very rare, absence of the nipple and usually associated with absence of the breast, amasia, polythelia, multiple nipples anywhere along whether one or both mammary ridges or mammary lines which extend from the axilla to the groin may be mistaken for a mole or a wart. Anomalies of the breast, amasia, absence of the breast, usually unilateral and associated with the absence of sternal portion of the pectoralis major. Polymesia, multiple breasts, etiology, persistence of extramammary portions of the mammary ridge, site, axilla, accessory breast, groin, or even the thigh. They may function during lactation. Infantile gynecomastia, diffuse enlargement of the infant's male breast, uni or bilateral, etiology, effect of circulating maternal sex hormones. Treatment, not indicated as it's usually reversible within 6 months. Blunt trauma to the breast leads to 2 lesions difficult to distinguish from carcinoma clinically, hematoma and traumatic fat necrosis. Sometimes it's the trauma which draws the patient's attention to an already existing carcinoma of the breast. Breast trauma, traumatic fat necrosis, pathogenesis, blunt breast trauma leads to death of some fat cells. Fatty acids are liberated and combined with calcium, leading to formation of calcium salps, 1 or 2 forms. Cyst or a hard mass. Cyst, this is the more common presentation. It contains thick oily fluid, while the hard mass, less common presentation, differentiated from carcinoma by biopsy, after excision, cut section shows characteristic chalky white appearance without yellow streaks and gritty texture of the carcinoma. Inflammations of the breast, acute lactational mastitis and breast abscess. Incidence, most common during lactation. Etiology, causative organism, coagulase positive Staphylococcus aureus. Source, from the mouth of the suckling infant. Mode of transmission, nipple cracks and openings of the lactiferous ducts. Blood-borne, less common. Pathogenesis, Staph aureus, induced clotting of the milk in ducts, leading to obstruction and stasis, which is called milk engorgement. Pathology, site, any part of the breast, at first diffuse. Stages, start by milk engorgement. If not properly treated, lead to acute mastitis. If not treated, staph produce necrosis and pus formation, leading to multilocular abscess. Clinical picture, stage of milk engorgement, site may affect the whole or a sector of the breast. Symptoms, dull aching pain. Signs, general. Persistent pyrexia, local. Breast enlargement and induration. No signs of inflammation. Stage of acute mastitis. Symptoms, the pain gets worse. Signs, general, higher pyrexia, local, diffuse swelling, redness, induration, and tenderness. Stage of acute abscess, 6 P's, then C, chronicity. Pain is throbbing, pyrexia is hectic, physical signs get localized in the breast, pitting edema is shown in area of skin overlying the abscess, persistence of local signs of inflammation for more than 5 days, or of severe systemic upset for more than 2 days after full antibiotic treatment, and finally the C4 chronicity stage of chronic breast abscess. In the first stage, no physical signs of inflammation. You have to know this. Breast abscess is one of the sites where the surgeon shouldn't wait for fluctuation to diagnose it. Treatment: before abscess development and when abscess is formed. Before abscess development, medical treatment. Antibiotic against staphylococci, amoxicillin clavulanic acid, supporting the breast to lessen the pain, local heat, warm fomentation, weaning. This is controversial. If the baby has been nursed for more than 9 months, advise her to wean. Commonly used, cabergoline, 0.25 mg per 12 hours for 2 days, and if the baby is younger, use the healthy breast for feeding to regularly empty the inflamed breast by squeezing and by a breast pump until resolution of infection. Then she can use both sides. Abscess formation is treated by incision and drainage under general anesthesia. Circumferential incision over the most tender area. Release the pus, sampled for culture and sensitivity. Surgeon's finger breaks down the septa between loculi, leading to formation of a single cavity. A drain is brought out through the wand or at the most dependent part of the breast. Antibiotic therapy may be continued for a few days and then the drain is removed when the drainage stops. Non-lactational mastitis, the commonest type, is that which complicates mammary duct ectasia. Clinical picture, painful, tender, red periareolar swelling, causative organism, anaerobes, Treatment: metronidazole or dalacin C in combination with amoxicillin clavulanic acid. Spontaneous or surgical drainage of the mammillary fistula at the margin of the areola require surgical excision. Investigations: ESR, CRP, culture and sensitivity for the antibiotic, and finally elevated total leukocytic count, ultrasound for the site and type of abscess, maturity of pus loculus, and biopsy if no response within 2 weeks. Prophylaxis: last 2 months of pregnancy, nipple retraction, good hygiene, and at delivery, clean the nipple after suckling and paint it with antiseptics if there are fissures. Mammary ductictasia or plasma cell mastitis. Etiology: unknown. Pathology: dilatation of major ducts filled with creamy, cheesy secretions. Periductal inflammatory reaction with round cells or plasma cells infiltration. Clinical picture: asymptomatic, nipple discharge, site from 1 or more ducts, character: blood-stained, serous, creamy white or yellow, retraction of the nipple due to shortening of the ducts, acute inflammation as mentioned before, recurrent and chronic inflammation, breast abscess near the areola. Treatment: for non-complicated cases, antibiotics, especially for anaerobes, and follow-up is recommended. Complicated cases, surgical excision of major ducts if mass or recurrent abscess or fistula is present through circumareolar incision. Nipple inversion is also corrected. Because of plasma cells predominance, plasma cell mastitis is the other name for the mammary ductictasia. The affected area is hard and associated with skin dimpling and nipple retraction, simulating the carcinoma. Chronic breast abscess is more painful than carcinoma and associated with low-grade pyrexia. Chronic pyogenic breast abscess. Etiology: inadequate surgical incision of an acute breast abscess. Antibioma: if abscess had been treated by prolonged use of antibiotics, bacteria are killed, but pus remains in the breast with excess fibrous tissue formation leading to sterile pus. Features: the breast abscess becomes chronically thickened with pus and fibrosis, leading to nipple retraction or skin puckering and simulate carcinoma. Investigations: ultrasound examination and needle aspiration. Treatment: due to thick fibrous wall, excision is the only treatment, and not only simple incision. Tuberculosis of the breast. Incidence: rare, associated with active pulmonary TB or secondary to tuberculous cervical lymphadenitis. Features: present as multiple cold abscesses and sinuses. The axillary nodes are enlarged and matted. Tuberculous toxemia may be present. Investigations: biopsy, characteristic tuberculous granuloma. Treatment: antituberculous drugs. With resistant infection, we perform mastectomy. Fibrocystic disease of the breast, or ANDI, or fibroadenosis, or cyclic mastalgia, or sector mastitis. Etiology: unknown, may be normal response to estrogen cyclic changes as prevalence in women from 30 to 50 years in the childbearing period and rare after menopause. Pathology: site, the upper outer quadrant of the breast. This is the commonest site. Microscopic changes: adenosis, epitheliosis, fibrosis, and cyst formation. Adenosis: non-neoplastic glandular hyperplasia leading to multiplication of the acini. Epitheliosis: solid epithelial hyperplasia within small ducts, if extensive, intraductal papillary growth leading to papillomatosis. In rare cases, there is atypical epithelial hyperplasia increasing the risk of breast cancer. Fibrosis: replacement of elastic and fatty tissues by fibrous tissue. If extensive, it leads to sclerosing adenosis, simulating carcinoma on mammography, differential diagnosis by true-cut needle biopsy. Cyst formation. Causes: obstruction of the ducts by epitheliosis. Size: small or large, micro or macrocysts. Pathology: lined with epithelium and filled with clear, yellow or brownish fluid. Incidence: most frequent disorder of the breast, and this stands for aberrations of normal development and involution. It's not considered a disease because it's a variation of the normal changes which take place in a healthy breast with menstrual cycles, pregnancy, lactation, and menopausal involution. A cyst may enlarge and hemorrhage occur inside it, leading to occult blood, and this is called cyst of Bloodgood. Clinical picture: may be asymptomatic, cyclic painful nodularity, small lumps. This is the most frequent presentation. Site, unilateral or bilateral. Timing: usually observed in relation to the cycles. May disappear when re-examined 1 week after the menstrual cycle. Could be accidentally felt lump caused by prominent cyst, aggregation of small cysts, or by the sclerosing adenosis. cyclic nostalgia, breast pain, common presentation, usually exacerbation of the premenstrual tension, timing few days premenstrually, associated with enlargement and increased nodularity of the breast, nipple discharge, usually clear or yellow, but sometimes brown to green. Investigations, usually not required, aim to rule out breast cancer in suspected cases, ultrasound and mammography, show cysts, aspiration to exclude malignancy, solid mass aspirated for cytology, when experience in interrupting cytology is not available or result is not conclusive, open biopsy. Treatment, priority, exclusion of malignancy and reassurance of the patient. Accidentally discovered cases, no treatment. Cyst, aspiration, if recurrent, exercise for biopsy. Nostalgia, psychological support, reassurance, breast support, wearing night and day a firm bra, good support and protection. Lifestyle support, giving up caffeine, coffee, tea, and chocolate. Primrose oil, 1 capsule every night relieves the pain. Topical NSAIDs as diclofenac gel, and prolactin inhibitors such as cabergoline, 0.5 mg per week for 6 weeks. Criteria of benign cysts: if the fluid is not blood stained, the mass disappears completely after aspiration, no residual mass, it doesn't recur within 2 weeks, and absence of any malignant cells on cytology. Cysts of the breast. Cysts of the breast usually arise from the duct system, acinar cysts, and occasionally occur in stroma, interacinar cysts. Acinar cysts, retention, galactosele, and intracystic papilliferous carcinoma. Retention cyst etiology, blocking, secreting mechanism by fibrosis from, without or by obstruction from within the lumen. Incidence, more than 75% of breast cysts are fibroadenosis. Number, solitary. Size, it differs from few centimeters to 2 inches in diameter. Fluid content, clear, serous, thick and greenish or creamy. Large cysts lead to blue-green color, blue domed cysts of blood good. Occasionally, the whole breast is occupied by large cystic spaces. Treatment is by aspiration. Galactosele or milk cyst, timing, during or shortly after lactation. Etiology, obstruction to one of the principal ducts. Pathophysiology, at first content is thin and milky, with dense and thin-walled cyst. The milk becomes inspissated and wall thickened and fibrous. Clinical picture, solitary painless swelling close to the nipple since lactation. Sometimes the milky fluid comes out from the nipple on pressing on the cysts. Treatment, excision. Intracystic papilliferous carcinoma. Intraacinar cysts, origin in the stroma, incidence rare. It includes dermoid cyst, blood cyst, and lymph cyst, and finally sebaceous cyst. Blood cyst etiology, traumatic hematomas, or other types of cyst with bleeding into them. Sebaceous cyst, site in the skin near the nipple, in relation to one of the Montgomery tubercles. Treatment is by excision. Nipple discharge, etiology, physiological, milk production with lactation, serous discharge during pregnancy. Pathological, ductectasia, fibrocystic disease, duct papilloma, hyperprolactinemia, contraceptive pills, and duct carcinoma. For ductectasia, this is the commonest cause of nipple discharge. The nature of the discharge is serous, creamy white, yellow, or blood stains, sometimes brown, green, or black, from multiple ducts. Fibrocystic disease, clear, yellow, brown, or green, from multiple ducts. Duct papilloma, blood or blood-stained discharge from one duct. Hyperprolactinemia, milky discharge, galactorrhea, from multiple ducts. Contraceptive pills, serous or milky discharge from multiple ducts. Duct carcinoma, rare, blood or blood-stained discharge from one duct. Diagnosis by history and examination. Nature of the discharge, association with a mass, uni or bilateral, the use of contraceptive pills, single treatment or multiple duct discharge. Investigations, lab and radiological. Lab, test for occult blood in the discharge if not apparent, cytology of the discharge for exfoliated cancer cells, and serum prolactin estimation in suspected galactorrhea. Radiological, soft tissue mammography and ultrasonography. Ductography, indication, single duct discharge. Disadvantages, not so practical, mammography is simpler and better. Treatment, for a palpable mass, excision for histology and treated accordingly. Single duct, bloody discharge, microdocectomy, single duct excision, multiple ducts discharge with no palpable or mammographic mass, conservative treatment by observation. Diseases of the male breast, gynecomastia, definition, generalized enlargement of the male breast, whether uni or bilateral. Etiology, imbalance between estrogen and androgen. We have physiological gynecomastia and secondary gynecomastia. Physiological gynecomastia, infantile, pubertal, and senile. Senile due to reduction of testicular function. Infantile, circulating maternal sex hormones, treatment not indicated, and never squeeze the breast. It usually resolves within 6 months. Pubertal gynecomastia, incidence up to 70% of normal pubertal boys. Clinical picture, asymptomatic, usually resolves within 2 years when adult testosterone levels are reached. And then we have secondary gynecomastia. Etiology, decreased production of testosterone after orchidectomy for prostatic cancer or testicular atrophy after viral orchitis and leprosy, or high levels of estrogen due to suprarenal tumors or feminizing testicular tumor, failure to metabolize estrogens in cases of chronic liver diseases, drugs, estrogen preparations, long-term administration of cimetidine, digoxin, and spironolactone, phenothiazines, and cannabis, ectopic hormonal production in bronchogenic carcinoma. Clinical picture, symptoms, breast enlargement, uni or bilateral with or without tenderness. Signs, subareolar mass, disc of tissue which is soft and mobile, any eccentricity in duration or fixation, suspect malignancy. This is not a possibility in children and adolescents. Examine the abdomen and testes. Investigations not required for neonatal and adolescent cases. Liver function tests and hormone assays in appropriate cases. Biopsy in cases of suspected malignancy. Treatment for physiological gynecomastia. Most cases require no treatment, only reassurance. Neonatal and adolescent types usually resolve spontaneously. Secondary gynecomastia, treatment of the underlying condition or withdrawal of the responsible medication. Persistent gynecomastia, treated surgically by subcutaneous mastectomy or liposuction. Carcinoma of the male breast, incidence rare. Because of the deficiency of breast tissue, it rapidly attaches to skin, chest wall, and ulceration is common. Differential diagnosis is from gynecomastia by staging and treatment similar to that of the carcinoma of the female breast. The usual operation is modified radical mastectomy. Chemotherapy and tamoxifen are usually indicated postoperatively. Prognosis worse than the female breast carcinoma. Breast neoplasm classification, benign and malignant. Benign epithelium, duct papilloma, mixed mesenchymal and epithelial, fibroadenoma. Malignant epithelial, carcinoma, mesenchymal, cystosarcoma phylloides, lymphoma, and fibrosarcoma. Duct papilloma, pathology, site in one of the main ducts near the nipple. It may ulcerate and bleed, leading to blood-stained nipple discharge. If it blocks the duct, it leads to formation of retention cyst. Clinical picture, type of the patient, young woman from 30 to 40 years. Symptom, bloody or blood-stained nipple discharge. This is the commonest presentation. Accumulation of blood in the duct, swelling felt deep or just lateral to the areola, small and fusiform, with its long axis pointing to the nipple. Pressing on it leads to discharge. If there is no palpable swelling, pressure on a certain point behind the areola leads to discharge from one duct opening. Investigations, ductography and ductoscopy, regular filling defect, ultrasound and mammography. Treatment, microdutectomy and histopathology. Excision of the affected duct, microdutectomy through circumareolar incision. If there is a lump, it easily leads to the duct. If there is no lump, the duct is identified at operation by passing a blunt-tipped needle through the discharging nipple opening. The excised specimen should be histologically examined. Fibroadenoma, pathology, microscopic picture, benign neoplasm of the breast which affects both the fibrous mainly and the glandular tissue. And there is another name, it's called breast mouse. Incidence, commonest breast mass of young women. There are two types, pericanalicular, which is the hard type, and intracanalicular, soft. Pericanalicular, the usual form, formed mainly of fibrous tissue surrounding few small tubular glands. They tend to be small. Intracanalicular, containing more glands, and they are usually larger and softer. Cross picture, well circumscribed, numbers, solitary or multiple, consistency, firm, smooth, surface, in big lesions they are lobulated, mobile, never attached to surrounding tissue, cut surface, lobules of whorled white fibrous tissue which bulges out of its capsule. Clinical picture, type of the patient, young age female from 15 to 30 years, symptoms accidentally discovered painless lump or lumps, signs breast swelling, small few centimeters, non-tender, spherical, firm, well circumscribed with smooth surface which may be bucculated, and high mobility within breast, called breast mouse. Investigations, ultrasonography and mammography. Well circumscribed lesion. When in doubt, TrueCut needle biopsy rules out malignancy. Treatment. For lesions more than or equal to 2.5 centimeters, excision and histological examination. For smaller lesions, follow-up. Phylloids tumors, previously wrong named as cystosarcoma phylloides. It's neither a cyst or a sarcoma. It's a giant intracanalicular tumor. It's a rapidly growing tumor resembling fibroadenoma. Type of the patient after the age of 30 years. Spectrum of activity is variable from benign, borderline, or malignant according to the cellular atypia, mitosis, and stromal overgrowth. Grossly, it may stretch the skin, ulcerate, and show dilated veins. Under microscope, compressed branching ducts like a leaf or a fern, therefore it's called phylloids. Treatment, excision with 1 centimeter safety margin. If the tumor is involving the whole breast, then we perform mastectomy. And this concludes our part for today for the breast.